And thank you, organizers, for this opportunity. So this topic also seems to be very interesting. And why it's interesting for us Indians? Because now India is also having its fair share of elderly people. So which was just 5% a decade ago, now we have 10% Indian population who classifies as elderly. And what is elderly? Anybody above 60 years. That's what the Indian definition and WHO definition is. So definitely we have to look after these elderly patients, and Dr. Prasad, who's professor and head Department of Nephrology at Andhra Medical College, Vizag, is going to let us know whether we should dialyze these patients or not. Are the outcomes good? Who should take the decision whether they go on palliative care or go on dialysis? So over to you, Dr. Prasad. We are eagerly waiting to listen to you.
Thank you very much, Dr. Manisha. Good afternoon, everyone. First of all, I would like to be thankful for this organizing committee and scientific committee of Indian Society of Nephrology Southern Chapter. So this is the basic outline of today's presentation, the basic demographics and prevalence of chronic kidney disease right now, and when to think about renal replacement therapy in elderly, and whether the conservative management versus renal replacement therapy, which is better, and the option should be given to which group of people we have to decide, and what are the benefits of early initiation of dialysis versus late initiation, and what are the prognostic factors. So by definition, elderly, the elderly definition was revisited. Now the elderly people who are more than 65 years old called as elderly population, and those who are more than 80 years, they are called as very elderly population. So this is the projections of elderly population in the world. So by year 1990, there is only 500 million of elderly population. Now by the year 2017, there is 1 billion. By the end of this century, there is a tripling of the elderly population. So that is nearly about 3 billions. Regarding this Indian scenario, right now we have nearly 134 millions of elderly population. That is equivalent to the population of Russia or Mexico. By the year 2050, it may cross nearly 300 millions, that is equivalent to the current population of United States. Out of these, more than 80 years of populations are nearly 12 millions, that is equivalent to a small countries like Cuba and Greece. So this topic is more relevant in Indian setup because we are in the fourth phase of demographic cycle, that is late expanding phase. The young nephrologists in near future, they have to see more and more number of elderly population with CKD. So this is the global prevalence of chronic kidney disease. The general prevalence of chronic kidney disease is in between 13 to 16%, whereas when it comes to the elderly population, so the age groups between 65 to 74, the prevalence is around 25 to 30%, and those who are more than 75%, the prevalence is around 45 to 50%. So if you extrapolate these prevalences, by the year 2050, nearly 60 million population of elderly suffering from CKD in India. So this is the age distributed mortality in the because of renal diseases in India. So in the southern states as well as the eastern states, the more elderly population are dying because of these renal diseases when compared to rest of the India. And in India in 1990, there is no much mortality reported, whereas by the year 2010, there is a lot of mortality, higher mortality reported in southern states and eastern states. And what is the resource burden of these CKD in elderly population? In 2013 itself, the US government spent nearly $50 billion to treat chronic kidney disease in elderly. If you extrapolate these figures to end of the century, it may be even more. So it may cause a lot of financial burden in the governments. So why the prevalence of CKD in elderly is more when compared to general population? Because the longer association with risk factors like hypertension, diabetes, and aging of the organs. Once we cross 40 years, there is a chance of losing 10% of renal function in every decade. And the association with decompensated organs. The kidney has to stay with the failed organs like heart, liver, and lung. And these people are more prone for infections because of the immunosuppression. And poor nutrition may also responsible for this increased prevalence, and they have less access to Medicare facilities. And identifying chronic kidney disease and label them as end-stage renal disease is a little bit difficult in two extremes of age groups and very low levels of EGFR. So we have equations like MDRD and CKD epidemiological formulas. Either they overestimate or underestimate the exact renal function. So here is a graph representing the MDRD and CKD epidemiological formula are more or less correlating with creatinine clearance. But what is the best way to diagnose or estimate renal function in elderly? Still there is a dilemma. So right now we can take its IDMS formula or CKD epidemiological formula with two variables like creatinine plus cystatin C. That will give a more near to this creatinine clearance values. So once a patient is an ESRD who are elderly, so whether to opt conservative or renal replacement therapy like dialysis or transplant. So the decision taking about conservative management depending upon various social factors and medical factors. The social factors are the patient should have a social support to take him for dialysis or renal transplant, and the financial assistance, because most of the countries they may not offer Medicare insurance to these people who are elderly of more than 65 years age. And life expectancy at the initiation of renal replacement therapy. For example, if the patient is having a lot of comorbidities, malignancy, and the life expectancy is less, so better to offer them a conservative management rather than renal replacement therapy. And we should also assess about the family support, whether the patient can be transported from home to hospital and taking care of the rest of the comorbidities. The family support is mandatory. And medical complications, first you have to look at the complex comorbidities, and frailty also play important role, and functional disability of the patient, and cognitive impairment, because these people have problems with memory, and they have a loss of complex thinking, and they have cognitive impairment. So considering all these social and medical factors, the patient should be offered an option of conservative management versus dialysis. So the survival analysis of conservative versus dialysis treatment, which is better? So definitely a conservative management in a disadvantageous position in those who offered conservative management, they have a nearly 60% of mortality rate in the first 6 months of uh, study. So whereas the dialysis group, they have good survival advantage over a period of 5 years when compared to conservative management, but the advantage is more in the early stages of initiation of therapies rather than later stages of the therapies. In comparison, the life expectancy in patients with ESRD, median survival is 13.7 months for renal replacement. Either it may be transplant or it may be dialysis together, compared with 13.9 months with maximum conservative treatment. So what are the conservative treatment offered to these individuals? So it is nothing but like a palliative care. Either it may be no dialysis or a short course of dialysis whenever they need it. So in between, they have been treated either to preserve the residual renal function, and they have to maintain the symptom management like pain, fatigue, pruritus, and fluid retention. Survival benefit versus symptom burden. So definitely there is a survival benefit in end-stage renal disease elderly if we offer them dialysis, but the problem is symptom burden. So they experience worsening of symptoms like pain, fatigue, pruritus, and constipation. And because of the high symptom burden, either they withhold or withdraw from dialysis, and they'll again go to the palliative care. So that's why once we consider not only survival benefit of hemodialysis, we have to assess the symptom burden following hemodialysis and before taking or before initiating dialysis in individuals. The choice of RTT, RRT, that is renal replacement therapy, what are the patient's choice? In US RDS in 2012, nearly 30% of individuals of more than 65 years age, they chose for renal replacement therapy rather than dialysis, and rest of the 70%, the major modality of RRT is nothing but hemodialysis. So initiation of dialysis after the age of 65 years. This is very relevant slide where in Canada itself, 85% of people, they experience the first dialysis after the age of 65 years. And rest of the United States, Europe and Australia, more than 50% of patients were initiated at the age of 65 years. In India, in our centers in AP, the average age for initiation of hemodialysis is between 40 and 50 years. So this is age cohort, so that regarding early initiation versus late initiation. Early initiation, the initiation of hemodialysis at the GFR between 15 and 20, and late initiation is between 5 and 10. The ideal study though show that the early initiation versus late initiation, there are not much benefit, but in elderly population, early initiation shows a little bit much benefit when compared to late initiation. So the mean GFR, if you initiate between 15 and 20, the survival benefit is better than late initiation in elderly population, particularly those who are aging above 70 years of age group. And the dedicated care pathway and routine nephrology. So when they were initiated in early stages, like in between 15 and 20 mils of GFR, routine nephrology care is enough to have a good outcomes when compared to dedicated care pathway if they initiated in a late GFR stage. So this is the DOP study where there is an increased number of people that are entering into hemodialysis at the later age groups. So this is the plan. Once we are choosing for hemodialysis, then we have to plan for a axis. Axis play a very important role in outcomes of hemodialysis. So before considering axis, we have to identify the patient's personal or individual goals, and we have to assess the frailty, functional disability, and the cognitive impairment, what it is called as patient life plan and axis needs. So axis creation to be initiated once the patient is fit to go for a dialysis by considering all these aspects of the patient. So age and survival benefit, definitely younger the age group of initiation, definitely they'll have a survival benefit. This is the slide showing the follow-up years of 10 years, where the people were categorized into 4 groups between 75 years to 90 years. Those who are initiated at the age of 75 years, the chance of survival is very high when compared to those who are initiated of above 90 years of age group. And survival and comorbidity index, here Charles and comorbidity score was taken in this slide. So the comorbidity index of less than 3, obviously the less than 3 or equal to 3 may not be possible because an advanced CKD carries a score of 2, and those who are elderly more than 65 years, the score is 1. So considering as elderly with CKD, the score itself is 3, but they have taken this as a equivalent to or less than 3. Those who are carrying more score of more than 10 carries a poor prognosis regarding the survival following dialysis. And systolic heart failure, the same severity of systolic heart failure of various age groups. The elderly will do, the younger people will do better when compared to elderly individuals of the same severity of systolic heart failure. So systolic heart failure is itself is a predictor of outcomes of hemodialysis. And vascular axis. Here the vascular axis also play. Lot of people who are initiated with a temporary vascular axis like tunneled catheters, IJVs, the prognosis is bad, not good when compared to those who are initiated with a permanent axis. In the permanent axis, AV fistulas do better when compared to AV grafts, because though there is a difficulty in creation of AV fistulas in elderly and the chance of thrombosis and rate of infection is high in elderly population, but still once the successful creation of AV fistula, the survival chance are better when compared to AV grafts and as well as temporary catheters. The functional status of initiation. So we have to assess the functional status after initiation. If there's a significant decline in the functional status following dialysis initiation, the patient may either choose to palliative care, or we have to look for other modalities of dialysis like peritoneal dialysis, because the functional status is very important in the outcomes of hemodialysis. So here what are the outcomes of octogenarians and nanogenarians in hemodialysis? There are three important factors. They will play very important role. One is age and the ambulation. The third one is comorbidities. So those people who are ambulatory, they will always do better with non-ambulatory individuals. And those who are having less number of comorbidities when compared to more number of comorbidities, even in octo and nanogenarians, they will survive better. So what are the comorbidities include? Albumin less than 35 milligrams, anemia, underweight, congestive heart failure, diabetes, ischemic heart disease, COPD, cancer, cerebrovascular disease and PVD. So this is the article we published regarding the predictors of mortality among patients on maintenance dialysis. So this is conducted in our hospital. We have a maintenance hemodialysis centers run by state government. So we assess the various factors in the prediction of mortality. So these are the factors we have studied: BMI, urine output, calcium, phosphorus, serum albumin, hemoglobin and ejection fraction, and intradialytic weight gain. So in this subgroup analysis, those people who are elderly, there is a 50% mortality rate after 1 year. So the predictors of this mortalities, those who are having good urine output, serum albumin of more than 3 grams, ejection fraction of more than 50%, intradialytic weight gain less than 3 kilograms, absence of LVH, and adherence to the schedule. So adherence to the schedule is very important because a lot of people, they are not compliant with hemodialysis, particularly elderly age group. So summary, the elderly population is growing and nearly all use HD as a modality. So the choice for elderly individuals is nothing but hemodialysis in India. When compared to US, nearly 30% are choosing for renal transplant. HD is not substantially different from PD in outcomes, and both should be offered to the patient according to their choice. The mortality benefit of initiating hemodialysis is likely reduced in patients with most comorbidities. Life expectancy is short for many elderly after dialysis initiation, but this varies widely based on comorbidities rather than numerical age. The factors affecting survival in elderly patients on hemodialysis: early initiation of hemodialysis, the mean blood urea nitrogen is 48%. Milligrams per cent, urban setting with better transportation facilities, and thrice weekly hemodialysis, they should be offered, and less number of comorbid conditions. These are the survival factors that we. So dialysis in elderly, what is the end game? So whenever patient comes to us with a end-stage renal disease, considering his age, the first we have to give a trial of dialysis. If the patient can tolerate dialysis very well, let it be continue. If they have a lot of symptom burden, then the survival benefit soon after, or we notice if there is no benefit in the symptom complex, or they have very advanced comorbidities and worsening of the existing comorbidities, either they may be withdrawn from dialysis and they can be offered palliative care. So thank you very much for giving me the opportunity.
So thank you, Dr. Prasad, for elucidating very clearly the indications of dialysis in elderly. So what we have understood, ladies and gentlemen, is elderly is a big number now in our country as well. We need to take care of them. Some things what Dr. Prasad made very clear, medical factors. As a nephrologist, we assess that whether this elderly gentleman goes for dialysis, fit for dialysis or not, we look at, he has told, only age, otherwise well, can go for dialysis if they want, but diabetics, those with cardiovascular morbidity, those patients, frail individuals, and we can use scores. So that extent you have made very clear. The other important thing, what is discussed nowadays is shared decision making. So my confusion is, when the elderly gentleman, otherwise whom we deem fit for dialysis, wants to go for dialysis, he is dependent completely on his son or daughter for the finances, and they don't want to take care of him, taking him to dialysis or pay for his dialysis. So what do we do in such a situation?
So this is quite a common problem in general practice. A lot of people, though they are interested in dialysis, because of the various social factors and financial assistance and attendance, particularly this hospital home transportation is very difficult. So those who can afford home dialysis, they can offer home dialysis, or otherwise they may be offered peritoneal dialysis.
Yeah, so you have solved the problem of transportation, but what about finances? If they don't want to fund, I think that is a question difficult to answer. So any questions from the floor? Yes, sir, please go ahead.
About the early initiation, I mean, it's always an issue. There is a lead time bias. So when you start somebody early, they live better because you have started very early when they did not require. So you cannot say that it's due to dialysis. It's always been a question. So I don't know, I mean, what is your practice? You said in one of the factors is early dialysis is beneficial, but it also, it's not very clear whether it is dialysis per se or it's a lead time bias. So what is your approach?
So early dialysis in elderly means, so we have to assess the GFR. The GFR is above 15, in between 15 and 20, but the GFR estimation is very difficult in elderly population. What are the equations? They may not be very much validated in GFR estimation. So considering the symptom complex and existing comorbidities, what the study showed that the people though are elderly, very frail, they may get little bit more much benefit if they were initiated dialysis early. So that means they don't have the much symptom complex. They don't have, if they don't have much symptoms. So instead of waiting for the disease gets so much worsened, instead of waiting for the comorbidities worsen, so they initiated the hemodialysis little bit early. So that is the concept behind a little early initiation of hemodialysis when compared to waiting till the symptom complex develops. That is the problem. Patients may not accept, but what the study is showing that.
Difficult
Any
to answer that
comparison
question.
between twice a week dialysis and thrice a week dialysis patients on longevity? How many percentage of your patients are you able to convince for a thrice a week dialysis?
So here the recommendations show that they have given thrice weekly dialysis only, but it depending upon the adequacy, assessing the adequacy and the symptom relief from the symptoms. But in this study, we have not mentioned about twice weekly or thrice weekly dialysis. But general recommendation is, like any other individual, younger people, they have to go for a thrice weekly dialysis.
Yeah, but again, like contrary to what we did when we were in PG days, what we used to do is, if they said twice weekly or once a week, we used to scold them and just told them don't come, either come for thrice or don't come at all. But now shared decision making, and now there is place for what we, as some of the government hospitals used to do earlier, lesser dialysis, depending on what they want, palliative dialysis or whenever they are symptomatic dialysis, or even once or twice weekly. So finally depends on what the patient wants and what goals the patient has in life. So thank you for a very nice presentation, and thank you for the nice interaction. Thank you for the opportunity.
I would request the chairperson to hand over the memento to the speaker, Dr. Prasad.